Good evening, everybody. Welcome to the webinar. My name is Sunny Bagla. I'm an interventional radiologist, and I will be presenting this evening on hip pain and hip embolization. And during the course of this presentation, if you should have any questions that you'd like to see addressed, please do us a favor and make sure that you ask them via the chat. If you ask them via the chat, we can pivot throughout the talk to make sure that we answer them either during the conversation or afterwards. There'll be people who are monitoring the chat room. In order to actually ask a question, you can either click on the chat button in the bottom left, or you can click on the Q&A button, and you can type your question in that way. So without further ado, I will get started. So again, my name is Sunny Bagla. I'm an interventional radiologist. I work alongside a number of other interventional radiologists who are also on the meeting tonight. One is Rachel Pachowiak, another is Faraz Khan, and another is Alex Puitapa. And the four of us work out of a company called IR Centers, which is Interventional Radiology Centers. It is the largest group in America treating different conditions with minimally invasive techniques. Even though we work in the urology space and in the GI space, tonight we'll really be focusing on hip pain within the orthopedic space. And so I'm going to get started on this presentation. So interventional radiology, for those of you who don't know, is a minimally invasive surgical field, and we do all of our procedures through image-guided techniques. So we use either X-ray or ultrasound or CAT scan to be able to do our procedures. And whether it's in the urology space involving the kidneys, where we may place catheters for people with kidney stones, or in the liver, we may do simple things like liver biopsies or treat hemorrhoids. We basically do all of these different types of procedures by putting small devices through just pinholes into the skin to treat many different conditions. And in the hip, just like other orthopedic conditions, just like in the knee or in the shoulder, our group was very critical in innovating a procedure which can treat patients with debilitating hip pain. And so to give you a background on really different types of hip pain, the most classic type of hip pain that people think about is hip osteoarthritis or arthritis of the hip. It is the leading cause of chronic disability in patients or people who are over the age of 70, and it's been designated by the World Health Organization as a priority disease because of how many patients that it affects worldwide. It is the most frequent joint disease, and it affects 10% of men and 18% of women over 60 years of old worldwide. And in terms of its impact, it actually is the highest cause of loss from work, where patients cannot actually perform normal work duties just because of the pain related to their osteoarthritis, and has a significant financial impact on the US economy, costing more than $100 billion annually. Compare arthritis of the hip to another condition which leads to hip pain, which is called greater trochanteric bursitis, or many people just refer to this as bursitis in the hip. And bursitis in the hip is a condition which causes pain on the outside of the hip, or we call it the lateral side of the hip. And sometimes it can actually extend towards the buttock as well. And this inflammatory condition is basically an inflammation of something called a bursa. And a bursa is basically like a cushion, if you can imagine. And it's a lubricant that allows the muscles and tendons to basically glide over the bone that is the primary bone of the hip or the femur. And when that cushion gets inflamed, it can cause very significant pain. It usually causes pain just when patients press on the outside of their hip or press towards their buttock. And it presents very differently, say, than a typical patient with arthritis, where a typical patient with hip arthritis may just present with difficulty moving their hip, but they can't necessarily reproduce the pain. So their pain is usually in the front of their hip joint, and they can't usually reproduce it by just touching it. It usually may present with either a grinding sound in their hip or decreased function and chronic pain. But when they press on it, they oftentimes don't know where the source of the pain is. With bursitis, the situation is that patients can actually elicit that area of pain. And this is very predominant in older individuals, but it actually has its onset in the middle agehood of between 40 and 60. And it's twice as prevalent in women as it is men. And when we look at treatment options for patients who have hip pain, whether arthritis or whether bursitis. The most common treatment options really are centered around weight reduction, exercise or physical therapy, taking pain medication or anti-inflammatories like Motrin or Aleve or ibuprofen, for example. And occasionally, patients will progress onwards to getting injections. And those injections can come in many forms. They can be anti-inflammatory type injections where we're injecting steroids, or they can be anesthetic medications where we're injecting long-acting anesthetics, sometimes to even just diagnose, is the pain coming from the area where we're injecting? In the setting of arthritis, we oftentimes will inject either lubricants or cartilage restoring type medications, such as hyaluronic acid or PRP, which is known as platelet rich plasma. Those types of medications may offer hope in trying to regenerate cartilage, albeit most clinical studies have demonstrated that they don't have very significant long-term effects. Now, these are the non-surgical treatments that are available for hip pain, whether greater trochanteric bursitis or osteoarthritis or classic arthritis of the hip. When you think about surgery, really the next option for surgery is to do something called an arthroscopy, where you put a camera in the hip joint and you look for something that might be affected. And that might be something called a labrum, where it's basically a cushion inside the joint that protects one bone from touching another bone. And oftentimes during arthroscopy, they can see, orthopedic surgeons will visualize areas where the labrum may be injured, and sometimes that can be surgically repaired via just arthroscopy itself. But more often than not, patients who progress to surgery for hip pain end up requiring hip arthroplasty, or what is known as hip replacement. Unfortunately, with respect to hip replacement, there are many complications, and they can involve loosening of the actual prosthesis where it doesn't settle in the bone very well. People can get secondary fractures or develop even new bone tissue within the muscle, where they grow new bone as an inflammatory condition. And of course, infection, which most people think about during any surgical procedure. The infection risk can be not insignificant during a hip replacement. And an important thing to know is that during hip replacement surgery, although it can be effective for pain and disability, approximately 5% may require revision surgery just within a 10-year period, and 15% may require revision surgery within a 20-year period. So, what is hip embolization, and where really does our specialty of interventional radiology, which performs these procedures through minimally invasive techniques, where does this procedure actually fit in with hip pain, and why does it work? So I'd say, so you can really get a good understanding. The word embolization means to slow something down inside of a blood vessel, including an artery or a vein or other channels within the body. So when we do an embolization, our goal is really to slow blood flow down to a certain organ or tissue. And the reason we block these blood vessels to an area in the body is this area in the body is often inflamed and has too much blood flow. So if you take patients with arthritis or patients with greater trochanteric bursitis, they have an inflammatory condition in their joint that leads the body to develop too much blood flow. So if you apply a procedure where you slow that blood flow down, you have the potential of reducing that inflammation and subsequently pain in that joint. And this procedure is performed by interventional radiologists who are specialized in these image-guided treatments. And I'll go into how we actually perform this procedure, but it's all performed through a needle hole and doesn't require really any open surgery. So I know this isn't really a talk that's intended to show pathology slides or histology slides, but the reason I show these slides is I wanted to really go through with you, like anybody should really, what we see when there's inflammation in a joint. So if you look at the slides on the left, these are slides that demonstrate what tissue may look like when there's not a lot of inflammation. But when you start to see a lot of inflammation, you start to get these little round purplish or bluish cells that start to appear. And these cells appear because they're inflammatory cells. And then with any inflammation, you start to get more blood flow. And on the right side of the screen, you end up seeing an ultrasound image. And this area of color, or this orange color right here, these are areas which demonstrate abnormal increased blood flow. So if you take somebody, for example, who doesn't have inflammation and you compare them to someone who does, you start to get what's called an effusion, which is fluid in the joint. And then you start to get this area of very profound increased blood flow around that swelling of the hip. And that's what's actually going on both histologically, meaning in the tissue itself, and then what's also going on when we look at it under imaging. So when we go on to perform a procedure where we do an embolization of the hip, what are we actually doing? So we place a small needle, it's actually the same size needle we utilize to draw blood, into an artery in the top of the leg. And then we put a small spaghetti-sized catheter. If you can imagine a piece of spaghetti, but it's a hollow tube, and it's very tiny. It's about 0.5, maybe 0.7 millimeters thick, so 0.7 millimeters thick, so very small. And we track that through the arteries, and we take that hollow tube into the arteries that supply the hip joint. And when we take the catheter there, we inject that catheter with a little bit of iodinated contrast. It's the same kind of contrast you've heard about during CAT scans, for example. And we inject that contrast, albeit it's a much smaller dose than you would get during a CAT scan, about 1/3 or 1/4 of the total amount of contrast is actually utilized. And when we inject that contrast, we see these nice looking arteries just like this. They're very tapered, very smooth, they're not diseased. But then when you go out into the tissue where it's inflamed, you start to get this almost paintbrush appearance where the arteries start to look smudgy. And we call this a blush, meaning there's too much blood flow in this area. The arteries are supposed to get smaller and smaller and taper off, kind of like this, where an artery goes down. But in this situation, the arteries actually terminate in areas that are really inflamed, and these arteries become very abnormal. So what do we do? When we get our microcatheter, which is what this little device is called, into the artery, we inject a little bit of a solution. It's actually like a salt solution. So if you can imagine these little salt crystals that go in and they slow the blood flow down to this area by plugging up these little channels. And over time, those salt crystals start to dissolve. However, because we have deprived this tissue of blood flow transiently or temporarily, the amount of inflammation starts to decrease. And so this is what this same person's angiogram or image of the arteries looks like before here in the middle and after embolization. So you can see how these arteries look very normal afterwards, but before, these areas that are smudgy with the areas of blush, they're very abnormal beforehand. This procedure is performed under a light twilight sleep. Patients do not require general anesthesia. They may actually get this procedure entirely awake. It is not a painful procedure to go through for patients. Like I said, it's done through a single needle hole, and it's done in an outpatient setting where patients get the procedure and then stay in our recovery area for a couple hours and then travel home afterwards. I will say that in terms of pain relief, what patients can expect is to really identify that they have less pain in their hip over a period of about 3 to 4 weeks. While there are patients who experience pain relief right away, meaning some patients experience pain relief immediately after the procedure and even the next day can notice a significant decrease in their pain score, most patients will see pain relief by about somewhere between week 2 and week 4 after the procedure. And the procedure is highly successful. It works in about 90% of patients that we actually perform the procedure on. And there are situations in which the procedure may be more beneficial to someone than not, and we can talk about that. There has been data on follow-up of these patients. So even though patients may get this procedure, people often ask, well, how often do they potentially have to get this procedure done in future? And the truth is, the success rates from what we know are very high, even in the intermediate term, meaning at 2 and 3 years after having this procedure, we know that most of the patients who get this minimally invasive procedure of hip embolization are still doing well at that 2 and 3 year point, and they're not necessarily having to move on to be getting hip replacement surgery. This is a slide which has a lot of numbers on it, but I really wanted to show this just to look at these numbers here in the pre and at the 6 months. This word WOMAC, WOMAC, is basically a scale we utilize to measure patients' pain and disability and physical function. And the lower the number, the better the patient is. And when you look at the pre-numbers of 19 going to 5, 6 going to 2, and 53 going to 22, or the total score additive of 77 to 27, that's what we inform patients when we talk to them, is that overall, they should expect about a 70% improvement in their pain and an improvement in their function. Now, while that may not be every single patient, some may see 90 and some may see 40%. And there are that 5 to 10% of patients who fail. Overall, when you look at the clinical success of this procedure, it's very high. And an important thing to note is it doesn't rule you out from getting surgery in future. So even for that 5 to 10% who don't get better, they could still potentially get a surgical option in future. And here's another example in somebody who has maybe a milder case where you see this area here and these abnormal arteries over here and here. And this is what this looks like before and after embolization. So when we think about who's really a candidate for this type of procedure, we really want to make sure that if you have complete hip dysfunction, meaning you're not able to walk or ambulate because that pain is so severe, or there's significant grinding in the hip, or you've had previous trauma in the hip that now limits your mobility, not just because you have pain when you press on your hip, but you can't even function by, say, walking in a way where you can get out of bed and do your normal daily activities. But it's really more of a function than it is pain. You might be more suitable for a hip replacement surgery. That doesn't mean that orthopedic surgery may not try this procedure first and call an interventional radiologist and say, hey, listen, I want to try this first before taking this person for hip replacement surgery because that is a major operation. But if you have chronic hip pain that's related to a pain that is your primary symptom, meaning, okay, doc, I got pain, but I can still move my hip around, meaning I can actually still have a good range of motion, but the thing that's limiting me the most is actually the pain. Those are patients who actually do really well from the procedure. The other types of patients who do really well is patients who don't respond to conventional therapies such as medication or physical therapy, but they may have gotten an injection and they got temporary relief. So they got a short-term relief, but they didn't get it for a long term. And it's important to know that those patients who feel the pain in their hip, meaning they can press on it, they tend to have even a better outcome than most patients do as well. Obviously, we want to see patients who are seeking an alternative to surgery. If you've made your mind that you want to have surgery, go through the physical therapy and recovery and have that hip replacement done, that is fantastic. But we want to see people who are obviously motivated to avoid surgery and prefer a less invasive option with shorter recovery times. If you're interested in learning more about this procedure, I've put a number here at the bottom of this slide in the middle that you can call for more information and set up a consultation with one of us in the practice. You can also send an email to LMG2, which is Loudon Medical Group 2 at ircenters.com. And you can learn more, not just about hip pain, but we can also talk more if you'd like about knee pain or shoulder pain, if those things are bothering you as well. Just to give you an idea, we don't just do procedures as part like this as part of our normal standard of care clinical practice. Because our practice has innovated these procedures over the last decade, we actually have novel clinical trials going on for not just these conditions, but others as well. And so you'll certainly be seeing experts in the field with respect to your orthopedic conditions. And last, if you scan that barcode in the bottom right-hand corner, it'll actually take you to a Google link so that you can actually be taken right to our website. So you'll be able to reach out to the office and set up that consultation directly. With that, I will stop sharing my screen as long as you've taken this number down. We can also put it in the chat as well. But we'll pivot here to answer some questions. And following those questions, we'll let everyone get back to their evening. And thank you guys so much for your attention.
Thank you, Dr. Bagla. That was wonderful information. The first question of the evening, you kind of touched on this a little bit earlier, but I'll kind of bring it back up, is do supplements such as hyaluronic acid really work?
That's a great question. So oral supplements that patients take typically do not have evidence in the medical literature that they work better than placebo. In terms of intra-articular supplements where we inject the joints, there is a mild amount of evidence that those injections will work in the knee and to a degree in the hip. More often than not, those injections may just prolong the ultimate surgical therapy for a short period of time, which can be only 3, say, or maybe even 6 months. It is important to note that injections, however, are an important part of a pathway of an orthopedic patient, meaning an injection serves two purposes. One is first to diagnose that the pain is actually from that joint. Many times people will have pain in their hip or pain in their knee, and the truth is that pain can be originating from the back. And so identifying that pain is better after the injection can make all of your physicians and care team at least comfortable to know that that pain is related to that joint. The secondary phenomena in and around doing an injection is that you may get a durable sense of relief from either a steroid injection or hyaluronic acid. But the evidence overall is fairly limited, but it is part of the standard of care. And I think that is important for patients to know that our goal is to make sure you follow that normal standard of care so that you're not missed for any other reason. I think that's critical with respect to injections. Marco, I think I got the next question. Can you hear me okay? I will go on to the next, Marco, there was a question regarding addressing the impact of the procedures versus other therapies like steroids in patients with long-term type 2 diabetes. And that is a great question, actually. In terms of type 2 diabetes, if you're a patient with diabetes or if you don't have diabetes, it's important to know that when we give patients steroids, it can, at least in the short term, affect their blood sugar. And while it may not have necessarily a long-term impact, it's important to know that steroids are not necessarily good in the long-term fashion, but even in the short-term fashion, they can actually pose, if given in repeated episodes, they can actually impact healing in the joint. They can impact cartilage growth. And so there are negative effects of steroids that you should know. And so with this particular procedure, it's important to know that we do not need to give you prolonged steroids. And this is often an indication that we're called to do this procedure. In fact, there are many times where patients are not candidates for surgical procedures because they have a high hemoglobin A1C, meaning their blood sugar may be higher than it should be in the setting of diabetes. And those patients may be referred for a non-surgical procedure such as this because the risks are increased during surgery. So this can have a significant impact in that patient population. The next question was, is this procedure suitable for a patient who's active and mobile but has hip pain at night while sleeping? And that is a classic sign of patients who usually have bursitis, meaning they have an inflammatory condition where at nighttime they're laying on their side or their buttock has pain. And it's because they're basically laying down with putting pressure on that side. And this procedure can be very effective in that patient population. And honestly, seeing that patient either through a physical exam, and sometimes we require imaging, but most of the time it can be diagnosed through a physical exam to see if a patient like that has bursitis and can improve. Um, there was a question about physical therapy and if it's required before a procedure. The key around physical therapy is that physical therapy is really the goal of physical therapy, right? Is primarily to improve function in any joint, whether it's the hip, shoulder, or knee. And oftentimes, pain can limit the effectiveness of physical therapy. If somebody has a chronically debilitated joint where their functions decrease, but they have significant pain, they actually may not be a great physical therapy candidate. And so that might be a patient who gets this procedure before PT versus the type of patient who doesn't have a lot of pain, but they're really limited by the function. And that's someone who may or should get PT or physical therapy before getting a procedure like this. And also, that is a very common first line option in patients who have joint related pain. Um, the next was, how is osteoarthritis of the hip diagnosed? It's a great question. And osteoarthritis in really any joint is at least first diagnosed by clinical examination and an x ray. So, just a simple x ray is usually the easiest way to diagnose somebody with hip osteoarthritis. And we use a standardized scaling system to do that. That's usually done in an orthopedic surgeon's office, especially here at Loud Medical Group. and they'll be the ones who typically diagnose you first with arthritis of the hip. And the next question after that was about ischial bursitis. Does this work for ischial bursitis? That's a great question. I will tell you early on, years ago, we primarily use it just for lateral or greater trochanteric bursitis, and more recently, over the past couple of years, for ischial bursitis with very promising and good results. I will tell you that ischial bursitis oftentimes overlaps with greater trochanteric bursitis, and so many of those patients probably get the benefit from both of those areas being treated. It can be, yes, very effective in that procedure. Um, the final question that we have in here is related to a patient who, for example, may have arthritis, and it could be radiating, and this is very common, and this can affect, and many of you may feel something like this at any given point with hip arthritis, is that you have pain, but it can radiate or redirect to other areas. It can sometimes go down the leg towards the back or to the groin area. And in that situation, it's oftentimes difficult to say if this particular procedure would be helpful without probably doing a physical examination or evaluating, because it's important to note that in the hip, there are other conditions like iliopsoas bursitis. Patients could have joint effusions. And truthfully, patients could also have back pain that's radiating to those areas. And maybe the back pain is not really predominant and they're really mostly feeling in their hip and thigh and buttock area. So those are the types of symptoms when you have, it's really important to be evaluated both with a physical exam and, of course, if needed, with imaging as well. Thank
If
you,
that's
everybody, for joining us this evening. And if you guys should have any other questions, please do not hesitate to email them to the LMG2 at IR Center's email. And everyone should have a great evening.
Thank you. Take care, everyone.